Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on respiratory failure under the section of respiratory medicine. So the definition of respiratory failure is inability to maintain adequate oxygenation and excretion of carbon dioxide. Generally speaking, there are two types of respiratory failure, type 1 and type 2. Type 1 happens when there is a respiratory failure in the context of hypoxemia or with low or normal CO2. Type 2 respiratory failure, on the other hand, happens when there is hypoxemia with hypercapnia, which is raised CO2. The causes of respiratory failure are quite varied and the list is quite long. However, the ones that are MRCP favorites for you guys to know, broadly speaking, is divided into a few categories. First, when there is reduced ventilatory drive, for instance, if there is a case of brainstem injury or opioid overdose. Second, if there is a mechanical problem, as in the case of severe kyphoscoliosis or obesity. C, in the case of some of the neurological problems, such as Guillain-Barré syndrome or GBS or polio. Fourth, if there is upper airway obstruction, such as OSA or sleep apnea. If you would like a refresher of OSA, please click here. Fifth, if there is a problem with lower airway obstruction, for instance, in the case of sputum retention or bronchospasm. And sixth, if there is any alveolar problem. And that can be then further subdivided into if there is a barrier to diffusion, such as in the case of pulmonary edema or pulmonary fibrosis. Or if there is a case of a VQ mismatch in the case of shunts or pulmonary embolism, or if there is reduced inspired partial pressure of oxygen, for instance, in the case of high altitude. As for its management, type 1 respiratory failure is treated with increased inspired oxygen concentration, whether that's through the cylinder or the wall on the ward, and if that is not still good enough for the patient, ultimately they may need to be considered for intubation in intensive care unit. Type 2, however, is frequently treated with mechanical ventilatory support, and sometimes it is quite rare these days with respiratory stimulant, such as doxapram, particularly in the cases where there is reduced respiratory drive. So let's do some questions. A 65-year-old lady with a history of osteoporosis and COPD presents to the medical take with a 3-day history of worsening shortness of breath, accompanied by productive cough of green sputum. On examination, she is noted to have severe kyphoscoliosis from previous spinal fractures and an expiratory wheeze throughout her chest. Which of the following arterial blood gas reading is most consistent with this presentation? So I'll give you guys a minute to read all of these. But having a look at these, option A is pH of 7.5, PCO2 of 8, PO2 of 10, bicarbonate of 22. Option B is a pH of 7.5, PCO2 of 8, PO2 of 7.8, and bicarbonate of 22. Option C is a pH of 7.31, PCO2 of 8, PO2 of 7.8, and bicarbonate of 22. And option D is a pH of 7.1, PCO2 of 8, PO2 of 12, bicarbonate of 22. And option E is a pH of 7.5, PCO2 of 6, PO2 of 11, and bicarbonate of 19. So looking at the history, hopefully you will remember that having severe kyphoscoliosis is one of the causes for type 2 respiratory failure, in which you have problem with both getting the oxygen in and also excreting carbon dioxide. And looking at the vignette, it sounds like this patient is also presenting with an element of decompensation resulting to expiratory wheeze throughout. as well as having productive cough of green sputum. So you should be suspecting a bacterial or viral infection that has basically exacerbated her COPD. So just by that information, those of you who work on medicine should know that the type of gas that you would be expecting for this patient would be a decompensated type 2 respiratory failure, in which you will have a low PO2, a raised PCO2, and very frequently patients are in acidosis. So by definition, option A, B, and option E are incorrect because they're not in acidosis. So really you're dealing with either option C or option D. And looking at these, C is the correct option because you have raised PCO2, you have low PO2, and you have acidosis. Option D is incorrect because your PO2 is pretty much normal. And that is the sign that this gas has been taken on somebody with potential of this history with COPD, but they're over-oxygenated. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.